It's my pleasure to introduce our next speaker, Dr. Jason Bartos, who comes to us all the way from Minneapolis, Minnesota. He's going to tell us a pretty amazing story about how to take care of people without a hospital arrest. He's extremely well trained at Stanford, has an MD, PhD, and is as passionate about this topic as probably anybody in the world. So passionate, for a couple of years, he was on call 24/7 for 2 years straight, never took a day off. And he's going to talk to us today about ECPR, is it ready for prime time, and tell us about the Minneapolis experience. Jason, welcome to Atlanta.
Thank you all. It's a pleasure to be here. I promise you it does not require 24/7 call for 2 years to do this. You can start in a different way, but that was my path. And the other thing to note here is that it's very important that I'm talking about the Minneapolis experience, because in the end, while there are certain themes that are true of most, if not all, ECPR programs, it needs to be customized to your local environment and your local systems. And so this is going to be very Minneapolis focused, but I will talk about where those general themes are in my mind, and certainly questions and discussion can come after about others that I might miss. I do have some funding from federal grant funding for grants and things, and then also some philanthropic funding from the Helmsley Charitable Trust that's related to this project as well. So we're going to start with just some epidemiology of refractory arrest. We've touched on that in other settings already today. And I'll show you the Minnesota part, because that's how we got into this, is to look at that data. Again, you don't know what you don't know until you have the data. And we looked at it and said, what about this whole group of patients here, and what are we going to do with them? Then I'll talk about the history of ECPR and sort of how our program came about, and then current state of what we do, and then what I think the future holds. So the epidemiology, you heard 300 to 400,000 out-of-hospital cardiac arrests, about another 200,000 in-hospital cardiac arrests every year in the US. It's the third leading cause of death if you think of cardiac arrest as an entity in and of itself, so it warrants a lot of attention, as you've already heard today. The data on the right in that graph shows you the trend in survival over the last 8 years or so. With the red line being the shockable rhythms. So the shockable rhythms always do better. The overall rhythm or overall cardiac arrest survival is in the dotted line there. There's a bit of a dip around COVID. This is something we saw in our community as well. Lots of reasons that may have occurred, but pretty consistent otherwise. Not a great increase or decrease in survival over all that time, despite, as Dr. Kudenchek was talking about this morning, all those trials and data that we had that were looking at how we might improve things. Not a lot has driven dramatic change in either direction. But when we look at the Minnesota data, again, this is 2011 to 2015 data before we started our ECPR program. Overall, we had about 7,500 cardiac arrests in our state during that time. Only a third of them are shockable rhythms. And these are ratios that you will see in your own data as well when you look at the graphs. So about a third of them shockable. And if you go from the far left, the all category, that's all cardiac arrest, then you go to the next data point, that's ROSC, the number of patients that got ROSC. So if you look at the overall population, about a third of them got ROSC, 7,500 to 2,500. So there's a big drop in survival. You lose about 5,000 of your cardiac arrest patients just with the requirement that you get ROSC. That's still true in the shockable rhythms, not quite as dramatic because you can defibrillate and have these other technologies you've heard about this morning. But still about half of your patients are lost if you require that ROSC is developed in order to survive. From then on, you actually have relatively stable survival, though it drifts down. You lose some people before admission to the hospital. You lose some people from admission to discharge, some people with catastrophic brain injuries and other reasons they don't survive once they're already admitted. And then the last category, that's CPC 1 and 2, that's the Cerebral Performance Category 1 and 2, which is a measure of neurologic outcomes. So CPC 1 is normal, CPC 2 is some mild deficits. You may not necessarily notice them talking to the person, you may, but those are considered neurologically favorable outcomes as CPC 1 and 2. So if you compare that last number in the red line, the 773 to 2,400, that was our percent survival, about 33 or so percent survival for shockable rhythms, much lower for the overall cardiac arrest patients. At this point, we thought to ourselves, we had generated some protocols to try to take care of particularly shockable patients. And we thought to ourselves, what are we going to do with the other half of the patients that don't get ROSC? that die in the field or die in our emergency departments, transported with ongoing CPR and nothing more to do for them. And if you think about the three sort of hurdles that it takes for somebody to get through their cardiac arrest to survival, the first and the biggest is that requirement for ROSC. The second is rearrest. About a quarter of the people, maybe a third of the people, depending on the study you look at, that get ROSC lose it at some point. That's where a lot of those that are transported to the ED with ROSC then don't get admitted because they rearrested in the emergency department. There are other reasons as well, but that's a big one. And then neurologic recovery, which is another big hurdle. ECMO takes care of the first hurdle. ECMO takes care of the need for ROSC. It does that by pumping the blood for you, taking over the function of the heart and lungs. So this is a schematic drawing of ECMO. You're pulling blood out of a major central vein, the femoral vein in this case. You're pumping it through an oxygenator that gives it oxygen, takes off carbon dioxide, and then pumps it back into an artery. And in this case, it's a carotid, which they actually do in children. We don't do that in adults, but we do the femoral artery in adults. So we're bypassing the heart and lungs, we're oxygenating, we're ventilating, and we're providing pressure. Functionally, it's cardiopulmonary bypass. This is what it looks like, at least at a leg level and groin level on the upper right there. So the two cannulas, the head is on the left, the feet is on the right. The two cannulas that are pointed to the left, that's the reddish one and the purplish one, are the actual ECMO cannulas that are pumping the blood. So the purplish one is the venous cannula, and the sort of the top one. The reddish one is the arterial cannula in the femoral artery, pumping the blood back into the person. That white cannula that's pointed to the right, to the feet of the patient, is the distal perfusion cannula. It takes a little bit of blood off the circuit and puts it down the leg to make sure the leg gets good blood flow, because you can easily occlude it with the arterial cannula. We use a machine the size of a bread box, which is called Cardial Help in most of Minnesota. Certainly in our center, that's most of what we use. That's shown in the bottom right, or in the bottom center, but there are other machines that can do ECMO as well. You just need a pump and an oxygenator and a machine that'll control that for you. And then the upper left is a schematic of that same sort of connection, the femoral vein and femoral artery. We typically use 15 to 17 French arterial cannulas. So these are large cannulas. This is about 3 times bigger than 2 times to 3 times bigger than what you'd use in the hospital for central lines or for sort of coronary angiogram access. And a 25 French venous cannula, commonly referred to as the garden hose. So it is a very large tube, and that's where some of the expertise comes in cannulation, is to place these large tubes safely. Therapeutic hypothermia or targeted temperature management is important. We don't really know what temperature is key for these people. We typically use 34 degrees. And then the bottom right, there are a whole bunch of data points that we can get from our machine, which we use for resuscitation in these patients. Even when we put them on pump, we still have to resuscitate them. So you use a lot of different data points to do that, obviously, and these are the data points that come from the machine itself. So as I mentioned, ECMO takes away the need for ROSC. It provides the ROSC for you, provides the blood flow. It also takes away the dangers of rearrest. If you do achieve a normal sinus rhythm while you're on ECMO and they go back into VF, that's fine, you've got them supported. One of the big jobs for me as we started this program in the ICU was to run to the patient to make sure that our very well-trained ICU nurses didn't start CPR on our patients when they went into VF, because they were supported by the ECMO pump. Their rhythm actually did not matter for the short term. And so it takes away the risks of that abnormal rhythm as well. But it doesn't really affect the neurologic recovery hurdle. We still have to get the brain through everything that it has endured up to that point. Many centers across the world have done ECPR. This is a few of the studies that were published as of 2017. They're coming, again, from all over: Japan, Europe, Australia, many centers. And you can see here, as it lists the different sort of characteristics of their program, that the third column there is where it's done. And it's done in a variety of places. It can be done in cath labs, the cannulation procedure in particular. It can be done in cath labs, which is how our system is built. It can be done in emergency departments, in the ICU. And there's some centers that do it in the pre-hospital setting, in the streets and in the museums and the subways of Paris. So lots of different ways to approach this, again, customized to the environment in which it's developed. This is a picture of one of those subways in Paris where they're doing it. You can see basically a tarp laid down, a patient on that tarp, people holding lights, and people dressed in surgical garb cannulating a patient down in the subway. This is how we do it in the cath lab with our cath lab team. It's a very different scenario and one we're very comfortable in. So it works very well for us, and it's very fast. So our shift for our program as we started the ECPR program was to take a cath lab and merge it with the resuscitation bay. We now are very comfortable doing resuscitation from cardiac arrest. We don't need to stabilize patients anywhere but in our cath lab. We bring our cardiac arrests who are unstable in shock to our cath lab. We feel like we're very effective, at least, at resuscitating, even if we're not placing ECMO. If they degenerate, if they do have rearrest, we can place the ECMO, but we can do all of the other aspects of code resuscitation as well. But that is a huge shift from how most cath labs are run. That is not a standard aspect of many cath labs. So that's something that takes a little bit of work. There are three fundamental tenets to an ECPR program, and this is definitely true for us. One is early mobilization of the patient to the ECPR center, cannulation center, whether it be a physical hospital or a pre-hospital setting. Wherever you're going to do the cannulation, you need to get them quickly. Every minute, and I'll show you some data for this, but every minute that goes by is 2.5% increase in mortality for these patients. So every minute delay is a very meaningful thing. So early mobilization is critically important. Then the first goal once they get there is to achieve hemodynamic stability. That's with the ECMO, pumping the blood, providing that stability, and finishing that resuscitation. So even when you get on ECMO, again, you may need pressors, you may need fluids, you may need blood products to resuscitate them and get them on the path to recovery. And then the third tenet is to treat the underlying etiology of the cardiac arrest. So you heard this morning some wonderful cases where that coronary occlusion was really causing problems. No matter what you do, you shock them out of VF, they go back in because there's an underlying coronary lesion. This is especially true in these refractory patients. About 64% of our patients have acute occlusions equivalent to a STEMI. And so until we fix that, we haven't really fixed the etiology of the arrest, and they'll continue to have abnormal rhythms or at least impede their recovery. And so that we want to be able to treat that, the ECMO provides that stability. This was our protocol. The details of this are not critical, but we started with this protocol in 2015, ages 18 to 75, shockable rhythms. So there are different ways you can design this program, but the low-hanging fruit for a program like this are people with shockable rhythms as their presenting rhythm. They may be shocked into PEA or asystole, but if they started as a shockable rhythm, that tells you something about the underlying etiology of that arrest and potentially the quality of the CPR that they can achieve, because the primary arrhythmia is causing the circulation problem, as opposed to other states where you may have other circulatory problems that make CPR less effective. So the most strict criteria for ECPR generally start with shockable rhythms. You do want refractory patients, so that requires that they get a few shocks. We choose 3, or that they're shocked into PEA or asystole, so they have ongoing refractory cardiac arrest. We require a Lucas CPR device. You could use any mechanical CPR device and sub that into this. Our belief from the beginning, and still is, that we don't want to encourage people to be doing manual CPR in the back of a moving ambulance because of the danger associated with that. Sometimes it's still done even in our environment, but we have a lot of Lucas devices in our ambulances. But safety is really important when transporting people with ongoing CPR. And so that's one of our safety measures for that. And then we wanted our patients to be within roughly 30 minutes of our hospital. And that's just to limit the very far or long transit times that could cause problems and reduce survival rates. Now, even if people meet all this criteria, they get transported to us, they're entered into the program, but we still do one more layer of screening, and that's based on blood gases, on arrival to the hospital. So when we're cannulating our first stick into the femoral artery, we grab a blood gas off of that and we check the lactic acid and PaO2 and look to see if this person has had a quote unquote successful resuscitation, meaning that their PaO2 is above 50 and their lactic acid is below 18 at that point. This also screens out patients for some of the things that can happen to them before EMS ever arrives, if they've been down for a long time or other things. But if they fit those criteria, then we go on to cannulate them. We always do a coronary angiogram right after we cannulate. We do PCI if we need to open up vessels, and then we go on to get them admitted to the hospital. As I mentioned, there's a lot of coronary disease in this refractory cardiac arrest population. So 84% of them have significant lesions. And again, 2/3 of them have an acute occlusion that you would otherwise call a STEMI if you get an EKG on these people. And that coronary disease is typically complex, split evenly between 1, 2, and 3 vessel disease. So a good number of these patients, if they came in with symptoms off the street, just walking into clinic, they would end up with a CABG. But in an acute setting like this, they're really not eligible for that. So we will go ahead and PCI everything that we can PCI for them. If they don't have any coronary disease, we may also do a pulmonary angiogram. We may do, if they have tamponade, we may put in a drain and remove blood. There are many things in the cath lab that we can do beyond coronary work to help somebody through their post-arrest state. The other aspect of an ECPR program is everything that happens after the cannulation. ECPR programs are a system that starts in the pre-hospital setting, starts with the first responders, starts with family members really recognizing there's a cardiac arrest. So we educate at all levels of our system. And that's, again, early mobilization is key. Then there's the cannulation piece, and then everything that happens in the ICU. And so this is really important data for us to look at how we work patients through the recovery process. And the overarching point is that the recovery process is long, and you need to have very dedicated ICU staff for this. So if you look at the graph in the upper right, this is just for people who survive and do well, neurologically favorable survivors. All of them are off the ECMO pump within a week and a half, but only half of them are following any sort of commands at 1 week. So really you have people that are essentially comatose for 2-3 weeks, and then they wake up later. Our policy from the beginning was to never prognosticate neurologically on a patient until at least 1 week into their stay, and unless they have catastrophic brain injury like herniation, unless it's clearly incompatible with life, but we otherwise don't make any definitive statements about how we think they're going to do until at least 1 week and preferably later. We have many patients that are starting to follow commands at the 2-week mark. Unfortunately, there are many patients that die despite everything you do, and you can do the best of ECPR and still pass away. And that's the bottom graph. Many of them die early within the first few days because of that catastrophic brain injury. And so if you look at the bottom left now of that table, that gives you the sense of survivors, the survival rates. So for us, 478 patients at this point have come through. If you look at the people who got the full treatment, they met all of our criteria, they got the ECMO, 37% of them have survived and gone home. And neurologically favorable status. They're basically undetectable neurologic issues if they have any. And if you look at just those that get admitted to the hospital, it's closer to 40%. So it's really, we can get a number of these people that would have otherwise died through their cardiac arrest with ECMO and all the support that comes before and after. For me as an intensivist, again, I'm an interventional cardiologist and a cardiac intensivist, and so this is important data for me entering that patient's room in the ICU. So every day of their stay, if they are not declared dead because of a catastrophic brain injury, but they have not followed commands yet, this is their survival rate on those different days from our patient cohort. So if you look at 14 days, the dot before 15, they still have a 30% survival rate, even if they're not following commands by 2 weeks. Many of whom are doing nothing, they're comatose at that time. Some of them may be moving around, but nothing purposeful. And they have not been declared dead. So this tells you that, again, you have to be very patient and wait a long time to really declare anything definitively. And we have people waking up at day 30 and 31. So post-cardiac arrest syndrome is an entity that's been known for quite some time, taken care of by many people in many ICUs. Typically thought of as a combination of brain injury, myocardial dysfunction, sort of a SIRS vasoplegic response, and then the underlying etiology. In an ECPR patient who's had CPR for on average about an hour by the time they get on pump, it includes every system, including trauma. So you have to be excited and dedicated to treating all of those different things. These patients are still eligible for dialysis, for surgery, for everything. They have to be considered fully eligible patients up until you've made a definitive diagnosis of poor neurologic outcome, which again takes a while. So they receive a lot of care and a lot of invasive procedures. Every organ is involved. You can see the ejection fractions on the left. This is split by survivors in blue, the people who develop brain death in green, and then the people in red who died of other causes. Everybody, though, has injury, but to varying degrees. So if you look at the people who are destined to survive, they still have reduced EFs, but they tend to recover within a week or so. Everybody else is reduced as well. Troponins can be very high. Creatinins bump in everybody. The LFTs and the glucoses, everything all very high as well. So you just have to have fully rounded critical care, being able to take care of all these aspects for these people. And then again, the trauma. The picture on the right is a quarter-size hole in somebody's right ventricle. This is a patient that we put on ECMO, and then they developed tamponade, and we had to bring them to surgery and repair that hole. And again, this is just a testament to the aggressiveness of the surgeons willing to take that patient to the OR to fix this hole, even though they've had an hour of CPR and they're comatose at the time. Without that support, this patient would have died. Instead, three weeks later, he left the hospital and is now playing the organ at his church again. So again, it just takes a lot of aggressive care to get these people through this. So as I mentioned, though, the primary causes of death are brain injury. So about 42% of the patients that died had brain death, 31% had anoxic brain injury of those who die. So the brain is really the limiting factor. That's what you all are doing in your care pre-hospital all the way through the code process, is trying to take care of that brain and delay the inevitable brain injury until we can get them on pump and stabilize them. There are 3 clinical trials that address ECPR at this point. The first is the ARREST trial that was done in the Twin Cities by us. This was a trial that was meant to randomize 170 people between ECPR, as I've described the protocol, versus standard ACLS. And unfortunately, or fortunately, we were stopped at 30 patients because it was unethical to continue to randomize patients to standard ACLS. Basically, our survival rate was 45% in the ECPR arm versus 6% in the standard ACLS arm. And they declared that unethical to continue to give people standard ACLS and stop the trial. So again, 30 patients in, 15 in the ECPR arm, and we had that survival rate, I think it's 43% in the end after a month. That one person who survived in the ACLS arm went on to die because they were trached and pegged and went to an LTAC and ended up succumbing to their illness. So no, really, at the point of our randomization, which was in the emergency department, it's very poor. After 40 to 50 minutes of CPR, your likelihood of survival is essentially 0 if you don't go on to ECMO. Their group in Prague randomized about 250 patients. They randomized in the field at about 5 minutes of CPR. So they had many more patients in the ACLS arm that survived because they got ROSC after those first 5 minutes. A similar number got ROSC in the ECPR arm. But then they would transport them to the hospital where they put them on ECMO, and they saw a significant improvement in survival at 30 days, neurologically favorable survival. But then they lost that statistical benefit at 180 days. So this trial is more of a mixed picture. That 180-day survival is an important primary outcome. That said, they also include all rhythms instead of just shockable rhythms, as I was describing. And this early randomization made those statistics a little bit harder to achieve. So this, again, it's different in its specifics compared to our trial. And then the third one is the Inception trial. That's the most recently published out of Holland. They started 10 centers for ECPR during the trial. So those 10 centers each started their ECPR work as a part of the trial. They randomized on average, or they treated on average 1 to 2 patients per center per year of the trial. So very low volumes compared to our volumes. And they showed very few survivors on ECMO. The vast majority of their survivors came from patients achieving ROSC after randomization. So this trial tells us a few things about the need for good experience and good volumes and how you sort of set up your ECPR programs, I think more so than it tells us whether ECPR fundamentally can work. I mentioned the time is so critical. Again, every 10 minutes that go by, you lose 25% of the patients. So 2.5% mortality every minute. If we have a patient get to us within 30 minutes, there are not many of them that get to us within 30 minutes, but if they do, we still have 100% survival to this day in our ECPR program. But we still lose them quickly after that, so that by 60 minutes, it's down closer to 25%, and then there's this trailing 10 to 15% survival out to 98 minutes, which is our longest. So we've now evolved from this hospital-based program to a mobile program to try to cut that time, to take patients to or take our ECPR to the patient, to try to reduce the time to get them on pump. And we do that at hospital sites. We go and cannulate at 3 emergency departments around the Twin Cities, and now we've got the truck. So we can bring it to people's front yards. Our activation process, again, starts in the field. We have paramedics that recognize ECMO patients. We've done a lot of training, a lot of work to give them criteria and to talk about it so they can recognize those patients and activate our dispatchers who will get our team to rendezvous with the patient at the closest site. And then we will cannulate them, take them to the cath lab there, and then bring them back to the university for their post-arrest care. These are the 3 centers. Somewhat strategically, but also accidentally spaced perfectly across the Twin Cities, so we can reach a little bit, again, closer to those patients, and those orange circles are now the 30-minute drive window roughly from those 3 centers, so we can really reach across the entire Twin City metro area. This is each dot represents a patient from the first 4 months of our mobile program. I will forever remember the optimism of paramedics when discussing drive time, because some of those dots are far outside the 30-minute drive window. but they still bring them. I think this program provides hope where there wasn't any before, and so we get patients from all over, and we are happy to receive them. This is the truck now to, again, take it out of hospitals and EDs and bring it to patients' front yards and Walmart parking lots. And so the truck is on the upper left. It's about a foot longer than a city bus. So this is a big vehicle. The floor of the vehicle is about shoulder height if you're standing on the ground. So you can see that in the upper right. We use a lift to actually bring the gurney up to the truck. You can see a picture in the lower right from inside. We have a C-arm, ultrasound, all the stuff we need for cannulation. And we have little rendezvous vehicles in the lower left there, normal SUVs compared to the giant trucks, so we can meet the truck wherever it needs to go. The future of ECPR involves patient selection first and foremost, knowing who's going to benefit and who isn't. We don't know all the answers to this at all, but we're developing the data. Little tools like this, and I'm not going to belabor the details, but we need decision trees. We need ways to integrate the limited amount of data we have when they arrive to us so that we have a better idea of who's going to survive and who not, and we can make informed decisions as a program about who we're going to choose. Whether it's green, everybody gets ECMO, yellow, many of them will get ECMO, or centers may choose to do it or not, and then red, really nobody should, and that's probably those people with a 3% or less chance of survival. The other future direction is neuroprognostication. Once they're in the ICU, how do we know earlier whether they're going to do well or not? The AHA has a guideline for that for non-ECPR patients, for patients who have ROSC, but we really don't have all the data we need to do this in the ECPR population. This is some data from us just looking at a variety of neuroprognostication testing that you can do and how that relates to the prognosis. If what you want in the world of cardiac arrest is a highly specific test for brain death, meaning if it says it's positive, that patient will have brain death or some other form of death in all actuality, that they're going to die. And so you're looking for highly specific tests. And that's what some of these tests are, highly specific, but we just need to know more and have more investigation. The things that look the best at this point are the very initial CT scan, as they're going up from the cath lab for us, the cannulation site, and they're going to the ICU. We scan everybody. And if they have brain injury on that CT scan, that is highly specific, as well as seizures on EEG, and a very high neuron-specific enolase also is reasonably specific, but these are certainly still in development. And then ideally bringing the ECMO even closer to patients. And so for us in Minnesota, we have certain urban areas like the Twin City metro area, but we have a lot of rural areas where there's not a huge population. It's very hard to cover those areas without some more mobility. So the truck is meant to address some of that, but certainly helicopters and other ways have been used elsewhere as well. So, bringing the ECMO to the patient is always helpful. So in summary, just to bring it all together, so we have ECMO, which is a new link in the chain of survival. That's shown on the bottom there. It doesn't replace any links, but it's one more link. Every link is still critically important and has to be strengthened as part of an ECPR program. It is truly a full system of care, not just a machine or a procedure. Multi-system organ failure is ubiquitous in these patients, and you have to be able to treat it, and you have to be willing to dedicate the staff and resources to do that, to have the survivor rate that we have. You also need high-quality 24/7 multidisciplinary care. One group of physicians can't do it all. You need the surgeons, the nephrologists, the cardiologists, everybody on board. Recovery is very long, as we discussed, but it can be very durable, and people return to normal lives in that 40% of patients. They're back to normal lives, going on vacation, spending lives with families. So it's very rewarding work, but it's long and tiring. But strengthen those links, get out there and educate and talk through it and develop the system so everybody's on the same page. So thank you all for your attention. I'm happy to answer any questions.
Jason, that was a great review and very motivating. We have time for maybe one or two questions.
Jeff, I have a question. I'm interested in what percentage of people that are eligible for ECPR are you capturing?
Yeah, it's a good question because we rely on the EMS services to bring them to us. We are going closer, but still not every EMS service is doing it. So when we look at our numbers from the Twin City metro area, when we first rolled out the program, that was pre-COVID, like 3 months before, we caught all the patients in that 60, I think it's 58 that we had. We missed 2 patients. At that point, we had the run-in of all of our program before that, and so pretty much all the EMS services were on board and they were excited. Then COVID happened, And we lost a lot of that attention, and a lot of the people were bringing us patients and we had to turn them down, ICU bed capacity, all those things. And so we actually lost a lot of support. Now we're rebuilding it. We're getting back to that. But right now we're probably getting half of the patients in the Twin City area. So the data I showed you was largely pre-COVID. Some of it was intermingling during COVID, but it's a struggle every day. We also had a lot of turnover in paramedics and EMS in our area, and so we have to train a lot of new people too on the program, and that's been an issue as well. So COVID kind of set us back a bit.
Jason, quick question. What's your median days of an ECMO for these out-of-hospital arrests with VF arrest? And the second part is, I'm really impressed that at 30 days out, you still have people with, CPG and 1 and 2, CPC 1 and 2 recovery. So tell us when you feel it's worth waiting 30 days.
Yeah, it's a challenge. So the ECMO piece, so all of our survivors have come off within a week, but we still have people who are longer that we're waiting. We don't cut anybody off at a week. We keep trying. So we'll have people on average, the median time is going to be right around 11 to 12 days. We have a lot of the people who die, they die early. So that shortens that. And then we have the people who are just hanging on, hoping. The decision to continue is based on a lot of factors. It's basic ICU care in the sense that we're talking to families, we're looking at the overall picture, and we're talking to families about what this looks like for them. And there's a lot of variability in that decision making. If this person obviously didn't want much aggressive care, or they didn't want to be in a nursing home or a recovery rehab center for a while, and that factors into that family's decision making. But we have a lot of families that are really anxious up front, and we're trying to postpone things and say we don't know yet how they're going to do. But then once we get to the week or two, now they've bought in, and so they're willing to wait with us. And there have been a few cases that we've sent out, trached and pegged, and I swear they wouldn't have done well. I would have told you that from the beginning, and then they show up in my clinic a month later. And so I still am completely willing to be surprised, and I think we have to be open to that because it's just a very inexact science at this point.
Thank you, Jason, very much.